Good morning, everybody. How are you today? I hope you're doing well. My name is Sharice Magoon, and I am with UT Health School of Nursing. You are signed in to hear Dr. Wachman present on optimal care for substance-exposed newborns, how to implement change at your institution. We are happy to have you join us for the Texas NAS Awareness Month. These free CE presentations are sponsored by Texas Health and Human Services. So before we get started, I just wanted to go over a few housekeeping items. If you can please keep your microphone on mute at all times during the entire presentation, and also make sure that your video is turned off. We will be using the chat feature for question and answer, and Dr. Wachman will prompt you when she's ready for you to submit your questions. I am happy to introduce Dr. Wachman. She is an associate professor of pediatrics at Boston University School of Medicine and attending neonatologist at Boston Medical Center. She is a national leader in NAS research and quality improvement. She is currently the neonatal lead of Massachusetts NAS Quality Improvement Collaborative and one of the co-developers of the Eat, Sleep, Console NAS Care Tool. She is currently the PI of 3 NIH and foundation-funded studies focused on improving the outcomes of pregnant women with opioid use disorder and their infants with NAS. And now I will hand it over to Dr. Wachman.
Great, thank you so much. It's my pleasure to be here today with you guys, and I'm sorry that it's not in person, but one day. So I'm here today to talk about optimizing care for infants who are substance exposed at your institution. So I have no conflicts of interest to disclose. So this is a little bit of an overview of what we'll be talking about today. I'm going to be going over first starting with parental engagement, how to optimize your care location for babies with NOWS, non-pharmacologic care, feeding practices, how to assess NOWS, and as well as medication regimens, and then preparing for discharge. And we will take breaks for questions throughout because I know that's a lot. All right, so let's start with prenatal engagement. So I strongly believe that preparing for a successful hospitalization really starts pre-delivery as much as that is possible at your institution. We have found that to be really key for us in Boston Medical Center. And so if there is any way to do some sort of prenatal consultation with the mothers, that is recommended. So that person doing the consult can really be, anyone that has the information. So at our institution, it's actually the obstetricians within our clinic that do the consult. In many places, it's a pediatrician who's going to be taking care of the baby. But I think the most important part is no matter who it is, that the communication is consistent, and that you're giving them the same message. Because I think one thing that I've found to be problematic, working at other places, is if they're told one thing by one provider and something else by someone else. So making sure that the messaging is the same, no matter who is communicating that, is really key. And the goals are really to dispel any myths about NAS and about the process, to really prepare the family for the hospitalization, and ideally to involve both the maternal and the pediatric providers in the conversation. So these are the things that we typically talk about with the family pre-delivery. First, we talk about anticipated pregnancy outcomes and really just trying to make them fully understand, what we would expect, and again, dispelling any myths that they may have heard. We talk about concurrent substance use as well as psychiatric medications that they're on. At our particular institution, we really try to limit the number of additional medications that they're on as long as it's medically appropriate. We'll review our NOWS protocol for assessment and management. We talk a lot about breastfeeding, which we'll get to soon. And we really spend most of the time really preparing them for rooming in. And the messaging is really that you are the primary treatment for your baby. We want you to make arrangements so that you can be at the bedside. And part of that may also be identifying a support person to be with the mother. Some of the other things that we often do to help facilitate the rooming in is that we will often arrange for the mother to get guest dosing of her methadone right across the street from the hospital. So if there's arrangements like that that can occur, or speaking with residential programs to talk about permitting the mother to room in, during that time period that she's with the baby. So all of those conversations can happen pre-delivery. We also talk about the Department of Children and Families and the evaluation process that will happen after delivery. So we know that many moms do not come for prenatal care, or that they may be coming to a different site and you may not see them until delivery. And so this counseling definitely can start on labor and delivery, or at your first encounter with them, in the nursery. So definitely the same guidelines are here. And so for us, in order to make sure it's consistent, we actually give them a guidebook that has all of this information, so that we can make sure that what we're telling them is consistent. And so the OBs have the guidebook, the nursery has the guidebook, and we're able to then give them the same information no matter when the conversation starts. So this is an example of one of the handouts that's in our guidebook, and it just gives the moms some really concrete things that she can think about doing, and it helps to empower them to really be present and feel like there's things that they can do that really will improve the outcome of their baby. So highly recommend that you develop something for your institution that be given to the mother to give them some concrete things that they can do while the baby is in hospital. And this is the primary message. We really want to empower our moms to make them, realize that they are the primary treatment for their baby. So just to share with you, really the impact of this is we were able to look at the impact of having a parent present at the bedside in 86 of our pharmacologically treated babies on our inpatient ward. And so the nurses would document in the medical record every 4 hours the percent of the time that the parent was there, and we would come up with a percentage across the course of the hospitalization. And actually, we still do this to this day. It's a part of the vital sign for the babies, and we think it's so important that they're there. And what we found was the moms that were there all the time, that those babies were in the hospital 9 days less, which was really significant. And this was independent of all other factors, but just the fact of having a caregiver there at the bedside was associated with improved outcomes. And you can see it was associated with decreased length of stay, lower Finnegan scores, less morphine. All of this was statistically significant, and we really try to emphasize this with our parent and say, you being here really makes a significant impact. And, if you can't be here, we'll talk about, what we can do to help to still provide this care when you can't be here. So what is the optimal inpatient environment for babies with NIS? So I think no matter where you house them in your institution, the most important point is to keep them together. That is really, really key. I believe that, the ability to do that and the dyadic care, I believe, can best be provided in a place such as the postpartum unit or the pediatric inpatient unit. I work in the NICU. I see, I believe, those babies with NIS are not the sickest babies in the unit. And even if there is rooming and capacity within the NICU, it's really not the same approach as the care that's given, say, on the postpartum unit, which the whole focus is typically on the bonding of the mother and the baby. There's really a whole different focus of the unit compared to the care of an infant in an intensive care unit. However, NICU with rooming and capacity is still better than NICU with no rooming and capacity. So, whatever you can do to keep them together is highly, highly encouraged. This is a study that was done by Kate McMillan et al. That was published in JAMA Pediatrics. That was a meta-analysis that looked at different studies that compared the care of an infant in a NICU with no rooming in versus, I think the rest of them were in pediatric inpatient units. And you can see here that the rates of pharmacologic treatment, the risk ratio for requiring any medication was over 60% less, so 0.37. If you just keep them in the same room together. And this is pretty profound, and I think really says this really should be best practice recommendations. It's really strong evidence to support that this should be the way that we care for these infants, and we need to find a way to do this at each of the hospitals. So I hear this all the time from hospitals that we don't have a pediatric unit, we don't have anywhere other than the NICU to take care of these babies after discharge. So what do we do about this? Um, and so I think some of the hospitals that I have collaborated with in the past have come up with some really creative solutions. I think the one that I uh, would say that has been the most successful is that some hospitals have been able to actually continue to care for these dyads within the postpartum unit. And I think that is something that they were able to get approval for their hospital to really have these dual purpose rooms in which the mother and the infant will continue to stay there together, where baby is inpatient and mom is able to continue to room in. They've allowed the NICU physician to have care of the baby, but the baby would physically be on the postpartum unit. And this has worked relatively well for them. Otherwise, having the baby in the NICU, but having a place that mom can room in outside of the NICU is another option. But I think this dyadic care within the postpartum unit has actually worked well for a couple of the hospitals, and they've seen really significant improvements in their outcomes. If you can keep them out of the NICU and avoid a, say, 3-week hospital stay by just keeping them on postpartum for 5 days, I mean, there's a huge advantage of doing that for everyone involved. The second challenge that I've heard from folks is that we have rooming in, but the moms just don't stay. Sometimes they have to be at their program at night or they just leave. They have no interest in being there. And I'll tell you that that was certainly the case when we started our quality improvement project at Boston Medical Center. On average, our parents were only there half the time, and sometimes that was, even less. And so we were able to drastically change that just by changing our approach. And so we used to say, be here when you can, you know, and it was all about, the Finnegan scores and the medications. But I think changing the approach to say, as the baby's escalating in signs and symptoms, the first thing that we're going to do is we're going to put the baby back on you. You are the primary treatment. And so making them really feel empowered. And I think with that change in messaging, we were able to increase our parental presence by about 30% without even providing any additional resources. I think the change in the messaging, the partnering with the parents, made them really feel obligated to stay, and they wanted to stay. They felt like part of the team. The other thing that we have found to be really helpful is, similar to your collaborative, we have a collaborative in Massachusetts, and by educating the other members of our community, such as we've gone to our residential programs, we've gone to our DCF, workers, and really educating about how important it is that the moms are there. And I think that partnership with everyone in the community has really helped to allow the moms to be there, because we really feel that especially in that first week, that is where the mother should be, and it's going to benefit both the mother and the baby to be present during that week. So this was, again, our paper where we really showed just by this change in education of the moms in the non-pharm care bundle, we were able to increase the percent of the time our parents spent at the bedside by about 30%. And that's been maintained over the past 2 years. So I will take a break soon. Just one other quick topic before we stop for our first question break is, this is another question that comes up too, and this was certainly something that was a barrier at our hospital, was this perceived notion that the infants need to be on a monitor. And this often leads to separation. So for instance, in our nursery, our postpartum unit, we didn't have the ability to do in-room monitoring for the babies. And so the babies would go into the physical nursery to be placed on a monitor if they were started on medication. So the question is this necessary? What is the evidence to support monitoring? And we know that there's significant variability in practice. So for example, in Massachusetts, only about half of centers use any monitoring at all. Some of them, the other 50%, some use full monitoring, some use just SAT probes. And some of this, again, leads to the baby being transferred to the NICU for this perceived need for monitoring. So we've started to look at this at Boston Medical Center. Again, it's a pretty small sample size, but we just wanted to take a look and see our monitoring practices and what were the adverse events that occur on babies that are on pharmacologic treatment. So we looked at 81 babies who actually did not receive any medication, but were just on a monitor on our inpatient ward. versus babies that were on both morphine or methadone. And these were full-term, otherwise healthy babies. And we looked at the incidence of whether or not they had any bradycardia, desaturation events, or apnea. Um, and our protocol at the time was that they were on a full CVR and O2 sat monitor for the entire time they were on the pediatric unit, just per unit protocol. And what we found was that events did occur. So you can see in 10% of the controls, we were seeing these events, and in 19% of the babies who received medication. But I think really important to point out were what were these events that we were seeing. And so on average, the events were occurring 1 time per hospitalization. And it was primarily that they were dropping their heart rates down to the 70s, all self-resolved, no associated apnea. Or similarly, that they would drop their oxygen saturation to the upper 70s. Again, on average, 1 event per baby, self-resolved. So to me, I'm not sure the clinical significance of this, given that 10% of the controls had these events as well, and none of them needed intervention. And so we also didn't find any associations with whatever medication they were on, how much they were on, if they were on additional phenobarb or clonidine. So we've used this information to actually modify our guidelines at Boston Medical Center, where we went to sort of intermittent monitoring for a while, and then we transitioned to full, actually no monitoring for the kids in the nursery, which has helped us to allow the babies to stay in the room with the mother. So again, this is preliminary data, but I think just important to really look at the monitoring data at your hospital and think about if there's ways that the babies can be kept with the mother. Even if the hospital decides that monitoring is necessary, can that be done within the mother's room? Other things just to think about if they are in a NICU is, are they in a pod versus a private room, ideally in a private room or in a quiet pod, what type of bed you're using. Is this an open warmer versus can you put them in an isolette or, a crib where they can be swaddled? That's important as well. And really trying to cluster the baby's care so they're not being interrupted unnecessarily for things like exams when those can be clustered with times that they're due to eat and things like that. So there is a lot of other things that you can do, even if you're limited to have them, within the NICU environment. So I'm going to stop there for our first round of questions, again, focusing on sort of parental engagement and rooming in. So let me see if I can open up the chat here, and if I don't get to all of the questions, there'll be plenty of time at the end, and we'll also be, I will answer any questions I don't get to via email. I can fill them out and send them to you. I think there's a way that we can do that afterwards as well, but I will try to answer as many as I can. We can take maybe 5 minutes for questions. Let me just open this up.
If you want, I can read them to you, Dr. Wachman.
Sure, yeah,
Okay.
I don't have it pulled up here.
Okay, so Cindy asks, have you experienced pushback from CPS on mom being able to room in?
That is a great question. So, and I get this a lot from many hospitals. So we have at our hospital, about 25% of our babies are discharged in non-parental custody. With partnering with our Department of Children and Families, we actually have permitted the vast majority of our mothers, even if they are in DCF custody, to room in. Sometimes we do not allow the parents to spend the night. It really depends on the situation. But, so I think the cases, those 25% that are in non-parental custody, I would say for the most part, moms are still permitted to visit, to be in the room. And there's some instances where we don't permit them to spend the night, but I would say that's the minority. And that really, they're in a supervised setting, on our pediatric ward, so where we're able to, so they're not, by themselves with the baby. And we really are trying to be as supportive as possible and allowing them to be there with their child. And that includes, we even have had, many of our incarcerated moms continue to room in on postpartum and do all of the care. So that has been great. So no, we haven't received a lot of pushback from that. Actually, we've had a lot of support in doing that.
Okay, Melissa asks, how do you get buy-in from the hospital admin to allow mom to stay on postpartum
Mm.
after she has been discharged?
Yeah, so the hospitals that I've worked with that have done this really have looked at it from a financial standpoint, and they've presented to their administration to say, if we keep mom on postpartum for say 5 to 7 days, and that baby and mom goes home and baby gets no treatment, compared to a 3 week NICU hospitalization, and you do the cost, the difference in cost there, they were able to argue it in that way. And to say, say there's only, 1 or 2 babies per month. And these would be moms that are committed to rooming in. And I think that's the difference, is that if you're going to do this, it's a mom who has committed to rooming in and being there. And if that mom is committed to doing that, to keep them a couple extra days and to avoid that NICU stay, that is how they were able to do it. The exceptions to that are babies who mom is not committed to being there, that, the baby's going to be alone in the room. You might as well just send them to the NICU in that case. So these are really for those isolated cases where you say, you can argue, okay, there's going to be, say, 1 or 2 kids per month, that instead of staying for 2 days after a vaginal delivery, mom's going to stay for, 5 to 7 days to monitor. And, if the baby goes on a prolonged course of pharmacologic treatment, in those cases, maybe you do need to transfer at that point. But if you could give us a week and see what we can do with a committed family, I think, you're going to find over half of the time that the babies aren't getting medication with that sort of care. And it's going to be a lot better than taking up NICU beds, which then for us was spilling over to the pediatric ward, backing up into the ER. It was really having impacts on our whole pediatric unit by having these kids stay for, on average, over 20 days. So that is how they have been able to do it.
That was the last question.
Okay, perfect. Great. So I will keep going. Um, So I started to talk about this a little bit. So incarcerated women, we really treat them the same, that they are able to room in until they need to go back to the facility. And we use the same breastfeeding criteria, which we'll go over. And again, non-parental custody, we are permitting them to room in many cases. If not, we have had other family members. So frequently there is either the father or a grandparent who is able to provide the care if the mother is not permitted to remain at the bedside. And lastly, I think this is something that many hospitals have developed, are cuddler programs. Our cuddler program has been in place now since December of 2016. And this is a program that is a collaboration between our hospital volunteers services department and our medical school. And so we have 100 volunteers active at any given time. About a third of them are medical students, a third of them are hospital employees, and the other third are members of the community. They undergo standardized training and they sign up for shifts. They come every 1 to 2 hours between, I think it's like 4 a.m. and midnight. And they show up and they just hold the babies. Really their only responsibility. And so that has been tremendously helpful for those cases in which they have restricted all visitation for the family and for the babies in the NICU. And so that has been really, really helpful, and something that was actually really easy for us to institute at our hospital. I think the collaboration with the medical school has been great because the students have turned it into a service learning project where they get additional education on addiction medicine topics. So something that if anyone is interested, I'm happy to send information on that. There's actually information on our state website, which I'll share that website with you at the end. All right, so moving on to infant feeding practices. So most important thing is to set realistic expectations. To make the mothers understand that these babies have additional energy expenditure and weight loss, and oftentimes we need to either fortify the feeds, add extra calories and things like that. So oftentimes exclusive breastfeeding is not possible, at least initially in these families. And just to really set the expectations from the beginning, we have a lot of qualitative feedback that the parents did not feel fully prepared for that, and it was very disappointing for them to learn that sort of after delivery, to educate them about breastfeeding benefits, which we'll talk about, and to really feed them on demand without limits, which I'm sure Dr. Grossman mentioned, is really this really important in helping to treat some of their signs of withdrawal, and also to consider nasogastric feedings. That's often sometimes an intervention that we try if the babies are not meeting their goals. So with breastfeeding, so the studies have shown that with any amount of breast milk that's consumed by the baby, the studies have shown anywhere from a 7 to 44% reduction in need for pharmacologic treatment, associated decrease in length of stay, and we have seen that the most benefit seems to be with more exclusive breastfeeding. It is okay to breastfeed with hepatitis C. So we know that at least at our hospital, it's like 70% have hepatitis C exposure, provided there's no bleeding, cracked nipples. It's okay to breastfeed with hepatitis C. So I do want to talk about the eligibility criteria, which is, I know, a hot topic at many hospitals. So starting with methadone and buprenorphine. So these are, as you know, the standard of care for women with opiate use disorder in pregnancy, or that they are on MAT throughout the pregnancy. This is recommended because it, decreases obviously the mother's rate for relapse and overdose, but also provides a stable environment for the baby. And better birth outcomes. And so the transfer in the milk is actually very, very minimal. And so the benefits that the babies are getting from the breast milk is actually not thought to be due to the medication that they're getting transferred, but just due to the fact that all of us know how beneficial breastfeeding is in general. And we have seen a huge link between the breastfeeding moms and the moms that are at the bedside. So I truly believe that the breastfeeding is just a marker that the mom is there. And we emphasize that with our parents to say that I don't care so much if you breastfeed, I just want you to be here, because many of them choose not to breastfeed. So going back to this, really the concentrations are very, very low, and they're unrelated to maternal dose. That's a really common misconception that many providers and mothers have. And the lactation safety, so methadone and buprenorphine are considered L2 medications, and buprenorphine naloxone, which is Suboxone, is an L3. And they are all recommended for breastfeeding regardless of dose in a mom who is stable with her opiate use disorder. So actually more concerning are these short-acting opiates. So, moms that are on medications for pain, it's really, really dose dependent, that there can be infant sedation with higher levels. So really encourage everyone to look up the maximum dose requirements to see what is recommended. So this sometimes comes up in our moms that are very sick after delivery. Particularly moms in the ICU that we have babies in the NICU. So really important to look up this information, but these meds actually are more concerning than the methadone and buprenorphine for breastfeeding. So general recommendations about who can provide breast milk. So these are the guidelines from the 2015 American Breastfeeding Medicine. So basically, the criteria are that you want the mom to be in an addiction recovery program, that she has sought some kind of care for her addiction. Prenatal care is also important, that she seeks care for herself, and that there's no illicit or unprescribed drug use around the time of delivery. I think the most important point, and this is no matter what your guidelines are, is that there's a consistent approach across providers. I think it's really, really devastating for moms to hear inconsistent information about breastfeeding. I've been in some of these conversations where one person tells them it's fine, another person tells them they have concerns. So it really needs to be a consistent approach across all patients and providers. I don't think a case-by-case basis will work, because they all talk to each other, and it really needs to be, and who knows, one provider may feel differently from another. It needs to be an institutional guideline that is followed, and so that since we've done that at our institution, that's really, really helped with the partnership with the mother to have a consistent guideline. And I think, oh yes, I can have ours on the next slide. So, and just also important to understand the barriers that mothers have to breastfeeding. So of our eligible moms, only about, I think it's like 2/3 of them actually choose to breastfeed. Some of them, really there's additional barriers with maternal infant separation. Many of these women have a history of trauma. or they have additional fears about concurrent medications that they don't want to breastfeed. And we know that these infants are hard to feed in general because of their withdrawal. So there are many, many barriers that need to be often addressed. These are our criteria at Boston Medical Center, this took us many, many years to get to this point, and a lot of research that was done in order to come up with these guidelines. And our most recent publication is in press, and happy to share that once it comes out. But we have gone from a protocol where we used to require the moms to have, I think it was 12 weeks of negative urine toxicology screens, and then we went down to 4 weeks, and now we're down to admission. And that was, again, through research that basically showed that the timing of the maternal relapse in pregnancy had no correlation with their postpartum relapse. So we looked, pre and post 6 months, and found there was no correlation. So we were basically negatively penalizing these women who really were committed to breastfeeding by using this urine toxicology criteria. So really what we look at now are a couple of key things. One is what is in their urine right now, what is in their breast milk. And so we look at the tox screen on labor and delivery and in the infant. And then we really look at this black box in the middle. Are they in a program? Have they received prenatal care? As we found, those two were the highest predictors of postpartum sobriety. And so we look at those criteria. Most of our moms meet those criteria. We've been doing this policy now for about probably 2+ years with really great success. And we do have women who are not eligible at the time of delivery. We do have some reconsideration criteria, which again doesn't come up very often. We find that the moms that are continuing to use at the time of delivery are not interested in breastfeeding their babies. And so with this, we have been able to support breastfeeding in the majority of our mothers who really are committed to doing it. For formula feeding, so a couple things just to keep in mind is we have partnered with our nutrition colleagues to really have a goal of volume and calorie per day, so they're consulted on all of these babies. The data to support standard versus high calorie formula there's not a lot of data out there. There was one study by Deborah Bogan's group that did support use of a higher calorie formula. We at Boston Medical Center previously were using a high calorie formula. We have recently switched to starting with standard 19 calorie, and about half of our kids end up being fortified, within the first couple of days. So I think overall sort of inconclusive. There's no standard as long as you have, I think, close watching of the weight gain and the calories. I think that's the most important. There's also inconclusive data about whether you should be using standard or a low lactose formula. So really not enough evidence to make one recommendation versus the other for type of formula. So this is our next pause. If there's any questions anyone has about breastfeeding or infant feeding that you'd like to ask at this time.
We'll give everybody a minute, and then I'll
Okay.
see if they.
Perfect. Yeah. Any questions, or should I keep going?
I think you're good to go.
Okay, perfect.
Okay.
We'll keep going. All right, next topic. Oh, I thought this was going to come up. I put this in here because everyone always asks about marijuana. This could be a talk on its own. So I just put one slide on here just to talk about this, because what we have found now in our Massachusetts collaborative is this is the hot topic. This is what everyone wants to know, and there's no answer to be had about this. The problem with marijuana obviously is just the fact that it's now legalized in many states, the concerns about, and it's very common, I think up to 10%, 10 to 15%. And, the concerns about it are the fact that it is very fat soluble. It actually does accumulate in pretty high levels in the breast milk. And there's concerns about breastfeeding while under the influence of marijuana. The other concern is that frequently it is laced with other substances, which the mother may be unaware of. And there's really unknown infant outcomes of breast milk exposure. Like the initial studies that were done were done like 20 years ago with different concentrations of the THC. So really unknown what the impact of breast milk exposure is. And so the other limitation too is about testing. So, urine testing can detect use up to 4 weeks prior. So how useful is that, at the time of delivery? And so that is another problem. And what are you going to do with that information? And so our approach at our hospital has been really that we do screening of all pregnant women, not testing, but screening for marijuana use, and a lot of education, because what we have found is that most moms are actually unaware that this could be potentially harmful to their baby. And we have found that with that education, that moms either do one thing or another. They either stop using if they're, were an intermittent user, or they will stop breastfeeding if they really can't, and we'll refer them to services. And so I think that screening education piece is what we've emphasized the most, and we have not considered it an absolute contraindication for all of the reasons stated, is that it's really hard to test for like we can for some of these other substances. And really we're taking these on a little bit more of a case-by-case basis, but there is no, I think, standard that is agreed upon at this time. All right, so our next topic is assessing for nows, which I know Dr. Grossman talked about, so I'm going to be a little bit more general about this. So some general principles, no matter how you're assessing these babies, are that the AAP recommends inpatient monitoring for 4 to 7 days. Again, this is going to be a hospital-to-hospital guideline. We do recommend that you do some sort of toxicology screening on the baby. And ideally on the mother, and that you start assessing the baby ideally within the first 4 to 6 hours after birth. So not after they start to show signs, but really starting these assessments, within the first 4 to 6 hours of life. Really important to keep in mind a couple of other things. One is what type of opiate exposure it is. Is it a short acting where you would expect to see signs maybe in the first 24 hours of life? Or is this a longer acting agent like methadone or buprenorphine, which may take several days to develop? Also really, really important to keep in mind these other co-exposures. So, and I just want to talk about these for a second because this comes up a lot, particularly if you're still using the Finnegan score. Nicotine exposure. So from our experience, this is 80 to 90% of the mothers are using nicotine during the pregnancy, which causes in the babies, often in the first 24 to 48 hours of life, a baby who is hypertonic and jittery and irritable. So you can get over an 8 on the Finnegan score easily from nicotine exposure, but the baby has no other signs. So really important to keep that in mind. If you have a baby who's very sort of tremulous, jittery, high tone with nicotine exposure, but it's right after birth, that may be what it is. Same with the psychiatric medications as well. So a lot of the benzodiazepines, SSRIs, things like that can cause the same neurologic symptoms that are signs that opiates can, particularly things like tremors and high tone and things like that. So important to keep those in mind and how those may overlap with signs of opiate withdrawal, as well as cocaine. So if a mother has used cocaine within 72 hours of delivery, those infants as well may show signs of cocaine toxicity, which is typically, again, irritability, high muscle tone, tremors, all of those same things that you may see. So really important to look at what the co-exposures are. When you're looking at babies that have opiate exposure, you would expect, again, the timing to be later, particularly if it's a longer acting opiate, and you would expect to see opiate specific signs of withdrawal which are things like the autonomic symptoms, the GI symptoms, all of these things that you don't typically see with things like nicotine co-exposure. So really, really important teaching point, particularly for the students and others that are just learning about withdrawal, to understand that what you're seeing may not be opiate withdrawal. So also thinking about all the other variables, there's so many in terms of predicting now's outcomes. And we've talked about a lot of these already, and just to go over some of the ones that we haven't mentioned yet. So we talked about a little bit about maternal factors, but in general, babies that are exposed to buprenorphine tend to have less severe withdrawal than those exposed to methadone. Those exposed to short acting, you would again expect the withdrawal to occur sooner. And again, the co-exposures, what we have found is the more psychiatric medications you add, the more severe the baby's withdrawal. So the more polypharmacy, the worse the baby typically is going to do. We've also seen worse NAS with the babies that have illicit drug exposures. Gestational age, so we've actually seen that preterm babies have less severe NOWs than the term babies, and there also seems to be a relationship with the birth weight, that the bigger babies tend to have more significant withdrawal, and there's also been a published association with infant sex where males tend to have more severe withdrawal than females. So all important things just to note, and we've talked about all these other factors. And then lastly, there's all this unexplained genetic factors, which is part of my research is to try to understand that piece, which is to say that you really can't predict and that every baby is different. And that's really important to emphasize to the parents that despite their optimal care and everything that we're doing, we really don't know for sure whether or not a particular infant is going to require pharmacologic treatment. So one of my favorite pictures ever. This is Loretta Finnegan and I were at a conference together a couple of months ago. And so I do want to just briefly talk about this. So I know I was covered in detail before. So this is the big debate about what scoring tool that you should be using, the ESC versus the Finnegan. So many of you are very familiar with the Finnegan scale, which is here, where typically 3 scores over 8 or 2 scores over 8 and one or two scores over 12 usually means pharmacologic treatment. Some of the limitations of the score I've already sort of pointed out is a lot of the CNS symptoms can be due to other exposures. And the metabolic and GI symptoms are a little bit more specific. I think the difficulty is, again, if you have, say, a preterm baby who may have respiratory distress for a different reason. The other limitations are things like, sneezing and nasal stuffiness, all of these things that may not necessarily require an opiate to treat. So those are some of the things that have sort of called this scale into question. And so why change at all? So basically, if you think about it, with the old approach, there's a lot of focus on what the score is. And what we used to see was a lot of iatrogenic dependence, that we had babies that were on morphine or methadone that really were staying on for a prolonged period of time, and they were experiencing withdrawal again, trying to get them off. And there was really a lack of parental engagement in the process. And so if you think about what is your goal of care, I think all of us can agree that when we're taking care of these dyads, our goals are that we want the baby to be comfortable and we want to promote optimal parent bonding. And so if that is our goal, maybe there is a need to reassess the way that we are doing things. And so this is the approach that Dr. Grossman had developed, is really looking at this more function-based approach, not quantifying the withdrawal, but how is the withdrawal impacting the baby's functioning in these 3 areas, and really focusing on having the mom and the non-pharm care as being the first line of treatment. And so I think what has really changed at our hospital since we were doing this is that, we used to really before focus on the score, and you didn't look at the baby, you just looked at the number, you didn't have to talk to the mom or anyone, and we would just start the medication, where now there's a lot of huddling and a lot of discussion. And I would say the mom is an active part of those discussions. And so that has been the real change, is that there's a really thoughtful discussion about what will best help this baby, whether it be more non-pharm care or whether it is medication. And there's usually an agreement between the parent and the provider once they feel like they've maxed out on all of the non-pharm measures. And this is the checklist that we've actually built into Epic, where we really document, the presence of a caregiver. And if we've optimized all of these factors, if we really think this is first line treatment, let's document it and see what we can actually do. And so we've been doing this now for a couple of years as part of our NOWS flow sheet within Epic. And again, here's Dr. Grossman's paper, which I'm sure all of you guys have seen, which has shown a significant drop in their need for treatment since implementing this whole package approach. This is the tool that we've helped develop since then, which sort of tries to standardize the ESC NOWS approach. And we were able to replicate Dr. Grossman's results at our institution, Boston Medical Center, with this non-pharm care bundle, which did include ESC as well, which you can see was implemented actually 6 months after the rest of our approach. So it really is a package approach, and ESC alone did not result in these improvements. It was our whole change in culture. This was our length of stay drop as well, with about a week difference. So since then, we have then implemented this across our Massachusetts collaborative. And on note, I think there's a total of 9 collaboratives across the country that have either started ESC implementation or expressed interest. I'm just going to share the results of our Massachusetts collaborative right now. So we had 29 hospitals that participated in our education on this topic. We offered a series of summits and workshops as well as webinars. We provided a whole online toolkit for them, and we had 11 hospitals that implemented so far. A number of others are focusing on, other rooming in and other efforts first before implementing the tool. And so we did provide a full training manual, video reliability tool, training PowerPoints, case examples, as well as the EPIC build. And these are the results. So basically we saw about a 20% drop in our pharmacologic treatment rates across these 11 hospitals. And these are birth quarters pre and post their implementation date. And you can see that the improvements really started about 6 months before. And this is really important to keep in mind. Many hospitals think ESC is sort of a cure-all, where really it's a whole culture change that starts, much before you actually implement the tool. And same thing with length of stay. We saw about a 5-day drop, but again, you can see that it really started about 6 months prior to when hospitals formally switched their assessment tool. These are the regression modeling results. And so you can see that all of the results were statistically significant for all of our key outcome measures here. Drop in length of stay, drop in need for secondary agents such as phenobarbital, drop in opiate treatment days. And very important, the bottom here is that we did not see any increase in readmissions or ER visits within 30 days of discharge, which was reassuring. In addition, hopefully all of you have seen the July 2019 issue of Hospital Pediatrics. If not, I would highly encourage everyone to get that issue, which was an NAS-focused issue. They published 4 articles on ESC, which were all quality improvement projects, single center, that all showed sort of similar results, but really, I think, helpful for hospitals looking to implement this to read what those other centers have done. So bottom line, it's the gravy. It's not a magic bullet. It's really a package approach, with all of the articles have shown that you have rooming in and breastfeeding and parental engagement and all of these things. And once you've done that, to have this sort of more function-based, I would say more family-friendly approach to scoring and assessments sort of fits very well within this package. And I think that's a reason to consider doing it. Though, we've had hospitals that have done the rest of it and have done more sort of symptom prioritization of the Finnegan that have had similar results. So I think, something to keep in mind. This is not definitive evidence, but I think important to say that it's not just the tool, but it's the whole approach that has resulted in these improvements that hospitals are seeing. Next steps are, again, trying to get more data, to get some reliability validity data. And there is actually an NIH-funded study, which some of your sites may be involved in, that is looking at long-term outcomes out to 24 months. So that is the Act Now study, which will take a couple of years to get those results, but that will give us more definitive data comparing the various assessment methods. And just a quick note on copyright, we have, because the tool is still under development, it's not validated, we have really limited access to the training materials to the collaboratives where they're doing this very structured rollout, because again, it's very preliminary and we would rather release the full package once it is validated rather than releasing it, to the public at this time. So collaboratives that are interested in pursuing this in a structured, quality improvement manner can feel free to reach out to me for more details. So next up is pharmacologic treatment, and we'll probably go to the end and then I'll take questions at the end. So I think this is really, really important to point out, and this is something that we saw when we first started to do more non-pharm care, was that mothers really saw the medication as a failure. That it's really important to tell them up front that despite optimal non-farm care, that X% of the infants at your institution require medication. You know, so I tell them off the bat and say, that doesn't mean that you failed. You're still the primary treatment, but in addition to the care that you're providing, we're also going to provide medication to make sure that your baby's comfortable. And we're going to involve you in these decisions. And that has really, really helped with their guilt and feeling that the baby needs to be treated. These are the treatment options that are currently recommended. So first-line treatment in general, you want to use an opiate to treat opiate withdrawal, so morphine, methadone, or buprenorphine. And I'll go through some of the studies for that. And then second line, typically clonidine or phenobarb are the medications that are most commonly used for second line treatment. So morphine versus methadone. There have been two studies, one which was a multi-center randomized trial comparing these two medications. And this was a double-blind, double-dummy study. BMC was one of the sites of the study. And what it found was that there was a slight decrease in the total length of stay in the methadone group and decrease in length of treatment. And also, though it wasn't statistically significant, less of the infants in the methadone group required phenobarbital. And I can share that the long-term outcomes of this study were just published recently and showed no difference in the 18 to 24 month developmental outcomes depending on which of the medications they were on. The only difference was that the babies that were in the hospital longer who received phenobarb actually had worse neurodevelopmental outcomes. And that was the only significant association. So babies that got phenobarb that were hospitalized for longer did worse, but it didn't matter otherwise if you were in the morphine or the methadone group. With buprenorphine, so there's less evidence to support buprenorphine. It's really only been studied by very few institutions, I would say 5 or less, that are really using buprenorphine. This is the only randomized trial that has been published, and again, pretty small numbers. What they did find was that compared with morphine, that there was a shorter median length of treatment in the buprenorphine group, but I just want to point out that the morphine treatment length was actually very long, 28 days in this study. So I think there was some differences in the morphine protocol that they used compared to some of the other centers where they're only seeing about 2 weeks on morphine. So I think the evidence is still sort of inconclusive about buprenorphine. I personally feel that any of the 3 medications are fine at this time, as long as you pick one and have a protocol. That's probably the most important factor right now until we have more definitive evidence. Yes, median length of stay also very, very long. Clonidine versus phenobarb, there is inconclusive evidence. I cannot make a recommendation one versus the other. Just to keep in mind, if you're choosing one versus the other, clonidine typically has to be weaned in the inpatient setting. It does require blood pressure monitoring. However, there's less concerns about the neurodevelopmental impacts of clonidine, so that's one potential advantage. With phenobarbital, we have found it's particularly helpful with babies that have polypharmacy exposure. We found that this is often the only thing that really helps those kids. One advantage is that it can be weaned as an outpatient, but there are concerns, as mentioned, about the neurodevelopmental outcomes of phenobarbital. So those have to be weighed as well versus getting the baby out of the hospital sooner. So the next topic, so why the long opiate taper? So typically what happens if you look at the blue line, as a baby's going to peak in their withdrawal a couple days after birth, and then they will start to get better over the subsequent week. And so typically what we do with the red line is we'll start the morphine or the methadone, when the baby starts to peak, and we slowly wean it over the course of the next, say, 2 weeks. So the typical is about 10% per day. And they're in the hospital on average, treated babies about 21 days. However, we all know that it doesn't always go that way. And oftentimes this is what happens, is that the baby is weaning and then they get worse and then they have to go back up, and then you start the phenobarb and they're here for over a month. And so this is not too uncommon and still something that we often see in some of our more challenging cases at BMC. So why do we do this? And the answer is I don't know, because if your goal is that you want to treat them during their peak of withdrawal, why don't you just treat them during the peak of their withdrawal? And so that I think is the approach again that Dr. Grossman has developed, but sort of just makes sense. Your goal is not to titrate them onto methadone. Your goal is to treat their discomfort during that peak of withdrawal. And so we have been doing this PRN. Actually, we use PRN methadone. We've done it now since, October 2017. And so we have found this is actually very successful for about 90% of our babies are getting on average about 2 doses of medication around day 4. And we do still have 10% that are converted to the standard taper. And this tends to be the babies that have the polypharm, illicit drug exposure, no parent is there, that we knew were going to be a challenge, that those babies we do put on a more traditional taper. But we have found that the triggered, more symptom-based approach has actually worked quite well for the majority of our babies. So this was our publication on this last year in Hospital Pediatrics. So we found that overall we were able to decrease the median length of stay by about a week for babies that required pharmacologic treatment with less exposure to methadone in those babies. And we did see that there was no increase in our balancing measures of readmissions or ER visits in that cohort. So lastly, before we get to the questions, talking about preparing for discharge. So in general, you're going to follow your hospital guidelines for how long to watch them in the hospital. We recommend anywhere from 24 to 48 hours after the last dose of any opiate medication before discharge. With methadone, we have recommended 48 hours after the last dose, given it's so long acting. And most important is that they're sort of over the peak of their withdrawal. You don't want to be sending someone out the door who is in the peak of their withdrawal. And so if you're using ESC assessments, we really want to see that they're getting primarily no's, that they're able to be sort of easily sleep on their own, eating what you would expect, and able to be easily consoled. And that the parent needs to be able to maintain these non-pharmacologic measures in the home. Another point that comes up really frequently is that you need to be able to promote safe sleep. That is really, really key, that the baby needs to be able to independently sleep in a crib. You cannot be holding them 24/7 and send the mom home, because that's going to be a setup for failure. And so that is really, really something that we try to emphasize, is that you need to be able to, at some point before they go home, to put that baby down in the crib. The other thing that we emphasize is that their weight is stable, that there's stable oral intake, and that they have a plan of safe care for after discharge with the appropriate clearances by either social work and/or the Department of Children and Families, with verbal handout to the outpatient pediatrician. And so we really feel that these babies need a lot of support, particularly in the first month. So we have a specialized prenatal clinic, outpatient pediatric clinic for these families that sees them weekly initially. And we really feel like this type of support is very, very critical for these families to have that extra support. Really important to look at growth and oral intake. Making sure they get their hepatitis C follow-up is critical. We, in Massachusetts, refer them all for early intervention and also developmental follow-up. The other thing that we're recommending as well is ophthalmology follow-up. There's been an increased risk of things like strabismus, refractive errors in about 10 to 15%, particularly in those with methadone exposure. And so we do recommend a routine eye exam at 4 to 6 months of age, as well as, again, re-emphasizing the safe sleep education. They have been found to be at increased risk for sudden unexplained infant death. And then most importantly is that you're focused on the recovery and the health of the mother. So sending them to a practice, pediatric practice, where the providers are going to make sure that the mother is in treatment. So I think that's really, really key to think about, is making sure that you're covering the mom's health during the pediatric visits. So putting it all together. So I do want to just share, again, our experience at Boston Medical Center and within Massachusetts as a whole, and how we were able to make these really drastic changes. So our program, we're very fortunate that we have this whole addiction center at our institution. We have a specialized prenatal program for these moms. We have the pediatric clinic. So we realize that we're sort of a unique center that many places don't have all these resources. We see about 100 to 130 babies every year. The vast majority of our mothers are on treatment, and we've had rooming in inpatient pediatrics. And so before we started our initiative, we were using the Finnegan score. We were treating about 82% of our babies with medication, with an average length of stay of 18 days, which is about the national average. We were using phenobarbital about a third of the time. Only about 39% of our moms breastfed, and as mentioned, about 50% of our moms were staying after the baby was transferred to pediatrics. And so I just want to give you a sense of our staffing model, because many folks are saying, well, how can I possibly make this change at my institution? We have so many people involved. And so this is our staffing structure. We have these kids on 3 different units. So we have our mother infant postpartum unit, our inpatient pediatric unit, and our NICU, each which has a separate set of hospitalists and nurses. We also have a float pool of nurses, and then we have 140 residents that rotate every 2 to 4 weeks on different shifts. So we counted that was a total of 360 providers. And we needed to make sure that everyone was on the same page about this change, because this was a really drastic change for our institution. And so how did we do it? And so really we did this through a very structured quality improvement effort with PDSA cycles. So we had a committee that had representatives from each of the units that I mentioned. So nursing representatives, we had social workers, lactation specialists, everyone was brought to the table, and we met every single month and talked about this. And we came up with a set of interventions that we were going to do. And we actually did it over the course. Most of the changes were made over the course of about 6 months. And so really started with staff education. So we had a standardized PowerPoint that went to all of the nurses through like their required education. That same thing went to all the hospitalists, and we would do presentations every 2 weeks to all of the residents. We did a lot of in-person trainings and feedback. So that was really, really key to make sure that every single person was getting the same education. We started again with this change in prenatal messaging. We redid our guidebook. We had this whole non-farm care bundle, again, the handout that we gave the mothers. And we started with just modified Finnegan interpretation, saying that, instead of acting on the score of 8, just talk about it and talk about, how is baby actually doing? Are we going to treat with medication or not? And so we did that for about 6 months, which I think was really, really key to show people that not acting on the score was okay, and that you could talk about it and the baby was going to be safe. The other thing that we did is we actually did switch to methadone. We have had better luck with methadone at our institution. I'm really emphasizing that we were not going to treat them in the first 24 hours, and that whole point about the co-exposures, because I think before we were really treating a lot of nicotine withdrawal in our nursery, and so really doing a lot of education about that. And then 6 months later, we adapted the ESC tool. We started our Cuddler program. And then a year after that, we did the PRN dosing and these changes that I mentioned in our cardiac monitoring. So it was really a stepwise process, and having everyone at the table every step of the way and reviewing all of the cases on a month-to-month basis. So again, this was probably the biggest hurdle, was to get people over not acting on the score, and really looking at, well, if they're over an 8, have we optimized the non-farm care, and how are they doing with sleeping and eating and all of these things that we actually care about? And so that was probably the biggest hurdle, was getting people to feel comfortable with this change. And I think having nursing leaders on each of the units, or champions that truly believed in this effort, was probably the most important part, was that there were staff nurses on the units that were so committed to this project, and were able to take those first couple of patients and show their colleagues that this could be successful. So I think identifying those people at your institution is a really key step. So again, other things that we did that was helpful is that we had visitors from other successful institutions, namely Matt Grossman, come and talk to our hospital. And I think that was very inspiring for people to hear firsthand what other hospitals have done, and to inspire us to be able to do the same thing. And also, again, developing these standardized health streams, meeting with the hospitalists from each service, doing the in-services, and then we do annual education now. Again, we have a health stream video that they watch, and then they complete a quiz to ensure that everyone is doing this in a standardized fashion. So we have then, again, spread this throughout our collaborative. The way that we've done that, again, is that we have twice annual summits. We have had these dedicated day-long workshops that are specifically dedicated to teams that want to implement these changes, that we're able to do, more small group work at those workshops. Really, really impactful, I think, have been our nursing panels. People don't want to hear from me. They want to hear from the bedside nurses. And so getting those people up there at those workshops to share what have you done when this has come up, and having them share firsthand has been really, really successful. So if you have a hospital where you've implemented these changes that can then share with other hospitals, that has been really, really helpful. We've also had a number of community hospitals that have really taken leadership. So not just our tertiary care center, but the smaller center with a level 1 nursery coming to share their experiences, I think has gone a long way as well. Having our monthly webinars was helpful, and sharing our challenges and solutions. We've also done a lot of partnering with our outpatient pediatricians and our prenatal providers as well. And again, partnering with the state agencies, which you all are already doing, has been really, really helpful too. So keeping everyone in the loop about the changes that are going on, because that's also going to impact your outpatient pediatricians and the babies that they're seeing after discharge. It's going to impact the timing in which decisions need to be made about custody, because the kids are going to be in and out. And so everyone really needs to be in the loop about these changes. And so these are some of the results from our state collaborative. And so not just the folks that have implemented ESC, but just the whole collaborative of all of our 37 hospitals, and that we were able to see through this collaborative and the education provided, that we were able to get about a 10% drop in the number of infants that are cared for within the NICU, which is great. We've also seen a drop about 15% in pharmacologic treatment across the state since we implemented this state collaborative focused on more non-pharmacologic care. And the average length of stay has also gone down. So really through this sort of collaborative education, we've been able to see a real difference across the hospitals in their sort of key outcome measures. So in conclusion, really most important is this parental engagement non-pharm care. Would really encourage everyone to make changes in a stepwise fashion, not try to do everything at once, but kind of pick one intervention at a time, and what's going to work best at your institution, finding out what the biggest barriers are. And then, lastly, we understand that there's still a lot more research that needs to be done to understand what the best approach should be before we can make definitive recommendations for, say, one medication versus another. So I do want to make a couple acknowledgments and then also share our state toolkit. So I want to thank everyone from the Act Now team, which is studying ESC further, everyone from Boston Medical Center, and our Massachusetts Collaborative. So the link that is there, you are welcome to use and share throughout your collaborative and hospitals. So we have created a NOWS toolkit, which has basically a summary of everything I just talked about, with a link to articles and sample guidelines on our website. And so we really don't want people to have to reinvent the wheel. So everything is there, and you can see there's a password there for the toolkit. The one thing that we have limited access to, as I mentioned, are the ESC specific training materials for the reasons that I've stated, but the general NAS guidelines and breastfeeding guidelines, all of that is available through the toolkit, and you're welcome to start there in sort of your improvement efforts. So that is all I have, and we have plenty of time now just to answer any questions that you have.
Okay, so we have a question from Lisa. It's a long one, so
Okay,
I'm gonna read it here. So, is the NEO QIC close to completion of validating the Eat, Sleep, Console tool? That's her first question. And then she says, our hospital system is building a homegrown tool because there are no current validated tools. My preference would be to wait for the Neo QIC tool so everyone is using the same tool instead of having multiple different tools, but the team
Mhm.
feels they need an
Mhm.
assessment tool to start managing infants with Eat Sleep Consult.
So great question. So I'll start by saying that there is no tool period that's validated for NOWS, and that's been the case for the past 40 years. So the Finnegan tool is not validated, and I think people don't realize that. And so what I can say from that, so with the ESC tool, what we've been doing for validation, so validation is different than reliability. So we do have reliability data showing that, you know, if you have one person's score and another person's score, you can get the same result. That we saw, it was like over 90% reliability, which is great. The validity part is this a valid tool to determine the need for pharmacologic treatment? And this is a valid way to assess withdrawal. And so the way that we've been doing that is that we have received input from 30 experts in the field to review the tool and give their input and then decide that yes, that they feel this is a valid way to assess. And so we have received that input and we've taken that input to incorporate that into the third edition of the tool, which is going to be available, I think, which is available now to those that are participating. So what I would say to that is, as I had mentioned, that we're not widely releasing this to centers that want to do this without data collection. If your center would like access to that version of that third edition of the tool, what I would say is send me an email. We have a system where we have like a copyright agreement where we can give you access to the tool, but not the whole training package, if that makes sense, but just the actual like one-page tool. We are happy to share with you after you sign that agreement. And I think that would probably meet the needs for your hospital. We unfortunately are not sharing the training materials because again, those are likely to change. And those, I think we are going to be ready to release probably after a little bit more data, likely the end of the Act Now study when things are sort of fully implemented. But if you would like access to the actual tool, send me a note and we can do that, because I would hate for you to start from scratch. And we do believe that even though it's not validated, it incorporates current best practice recommendations for things like the non-farm care. That should be best practice. Breastfeeding, rooming in, that should be best practice. So I feel like those aspects are supported and validated. But to get a fully validated tool, it's probably going to be a couple of years before that happens. And we've taken the necessary steps to do that. It's just not published quite yet. And I think this is the best that we have. And we're happy to share that after the agreements are signed.
Thank you. Any more questions, anybody?
Okay.
I'll give it a few more seconds. Maybe you are so thorough.
Maybe, I don't know.
So, and Dr. Wachman has her PowerPoint online, and we will be sharing the recording. You know, give us a couple days to do that. And that way, if you got, it seemed like everybody hung on. You had a good 72 people. So,
Okay, great.
yeah. All right. Well, I guess we'll say goodbye.
Okay, great.
No
Thanks, everyone.
more questions. We truly appreciate you being a part of Texas NAS Awareness Month, and coming on and talking to all the folks and sharing all your knowledge and helping us educate all these wonderful caretakers here in Texas.
Great. Thanks, everyone.
All right. Thank you. Bye.
Bye.